appreciate everybody coming out to the National Center for Policy Analysis Medicare briefing. I'd like to recognize sitting at the table Dr. John Goodman, who's the President and CEO of the National Center for Policy Analysis. He's been in that position since the National Center for Policy Analysis started 28 years ago, 29 years ago. 28 years ago, he says. And seated next to Dr. Goodman is Dr. Tom Saving, who's a professor of economics down at Texas A&M University and a former public trustee of the Social Security and Medicare programs and one of the country's leading experts. He has some of the greatest Social Security forecasting models in the country and was appointed by both Democratic and Republican presidents to serve as a public trustee and knows more about Social Security and Medicare than almost anybody that I know. The briefing today will be about Medicare. There were packets handed out at the sign-in table there. I hope everybody got a chance to get a packet. If you didn't get a packet, or if you have questions that were not answered in the packet, or questions that are not answered during this briefing, you can feel free to call me or to call Dr. Goodman or Dr. Saving. I'm Brian Williams. I'm the Legislative Director here in Washington, and my card is in the packet, and I can get you a card afterward if you didn't get one. So we'll start off today by hearing from Dr. Goodman. He'll present his findings about Medicare. Then we're going to go to Dr. Saving, and then Dr. Goodman will wrap up. And in between those presentations, there'll be chances for questions and answer. And then, of course, at the end, we're going to try to leave enough time for any questions and answers that you may have. Dr. Goodman.
Thank you, Brian. These are all the plans that most of you care very much about, all on one graph. And let me talk about them for just a moment. This is per capita spending on Medicare in real terms going forward, looking out many years into the future. And this very, very top line, that dark blue line, is the path we are on. And the path we are on is that Medicare spending is growing at the rate of growth of the economy as a whole, that's GDP, plus 2 percentage points. Now, what is the rate of growth of the economy as a whole per person in real terms? Well, for 100 years, real gross domestic product per year per person has been growing at 2%. That's the average for the last 100 years. Now, 2% plus 2% is 4%. And that's what healthcare has been growing at for the last 40 years. For 40 years now, the average is healthcare spending is rising at 2% per person per year in real terms. So healthcare spending in our economy is growing at twice the rate of growth of our income. And you don't need to be an economist or an accountant, or you don't even need a pocket calculator to know that if you're buying something and its cost keeps going up at twice the rate of growth of your income, eventually it's going to crowd everything else out, right? And in fact, if we continue on the path that we're on, we'll get out to mid-century and healthcare will crowd out everything else that we want to consume. So for most of you in this room, by the time you reach the retirement age, there'll be nothing left but healthcare. You'll have nothing to eat, nothing to wear, no place to live, but you'll have really great healthcare. Now that's the path we're on. The reason we say it's unsustainable is you can't get by with only healthcare. And that's the problem everybody is trying to deal with. Now this light blue line right here, that's what the Affordable Care Act does, what some people call Obamacare. And what it does is it instructs a commission to make sure that Medicare does not grow any faster than the rate of growth of GDP. So we call that GDP plus 0. In other words, it's going to grow no faster than our national income. So when Republicans say Democrats don't have a plan, actually they have more than a plan. They have a law that they've passed. And this is the forecast for what it's going to. This is the path we're on. This is the changed amount of spending on Medicare. This is at least the way the Medicare trustees look at it. Now, the Congressional Budget Office looks at it in a slightly different way. Remember, the Medicare trustees are the Secretary of Health and Human Services, Secretary of the Treasury, Secretary of Labor. These are all President Obama's appointees. So when we look at the trustees' report, we think of that as the Obama administration's view of its own health plan. Now, what does it mean for Medicare to grow no faster than the economy as a whole? Well, one thing it means is that what spending on seniors is going to fall way behind what everybody else is spending. We'll talk about what that means in just a moment. But it also means that if we could really do that, Whereas if we implement that law and nothing ever changes, then basically the problem of Medicare is solved going forward. If Medicare grows no faster than the economy as a whole, what that means is the money coming into Medicare is going to equal the money coming out. What is the money coming in? It's the payroll tax, the income taxes, and the premiums. And they grow with income. And so if the money coming in is growing at the same rate as the amount you're spending, then basically Medicare is paying its way through time, and that's one way to think of the problem being solved. Now the Ryan proposal, I don't know why there's so much talk about Ryan's proposal being, radically different from what we've already done. In the Ryan bill, for the first 10 years, there's no difference between what Paul Ryan has proposed and what's already passed in the Affordable Care Act. And for that matter, for everybody over the age of 55 going on until the day they die, there's really no difference at all between what Paul Ryan proposed and what's already law in the Affordable Care Act. So if the Ryan proposal were law, he would have the same problem that Obamacare has in trying to spend a lot less on seniors than what everybody else is spending. We have two different ways of looking at the Ryan proposal. Somebody in Ryan's office told the CBO to assume that Medicare spending grows no faster than the Consumer Price Index, and were that true, then Ryan's spending would be well below what Obama spends. And a different way of looking at it is to assume that Ryan spends no more than the rate of growth of the economy as a whole. And if that happened, then the Ryan proposal and the Affordable Care Act are the same. Also on this graph, I have a whole bunch of other folks. Bowles and Simpson, that's the Debt Commission. Ryan and Rivlin, that's Ryan getting together with a former Democratic head of the Congressional Budget Office. Domenici and Rivlin, that's another Republican Democrat getting together. All those folks said, well, we want Medicare to grow at the rate of growth of the economy plus 1 percentage point. So that kind of puts them in the middle. When Simpson and Bowles were in Dallas in the early spring, I asked them about this, and they said, look, we don't have a plan. We just have a line on the graph. We would like to see Medicare grow that way, but we don't have any plan to make it grow that way. And there's a sense in which everything up here is just a line on the graph. And that's a sense in which none of these people have ever said, how all this is involved shifting of problems. Shifting of problems to seniors, shifting of problems to future old people. But it doesn't have, there's no mechanism for helping these people deal with the problem. In other words, if you say to seniors, we're going to spend less on you, well, then what new tools do you give them to let them make up for that difference? None of those are here. Or if you say to young people, the government's not going to spend as much on you as we have planned, well, what new tools are there for young people to save so they can make up the difference? There's none of that going on in any of these plans. Now, what would it mean if we kept the Affordable Care Act as is? I said it solved the problem. This is the 75-year unfunded liability in Medicare. We immediately cut it in half the very day that President Obama signed the Affordable Care Act. This is the unfunded liability looking out forever. We essentially got rid of $53 trillion of unfunded liability the day President Obama signed the Affordable Care Act. That's huge. So huge that you wonder why the White House never said anything about it. This isn't a small improvement, this is enormous improvement. But how do they get it? Well, according to the chief actuary of Medicare, the way they get it is by reducing payments to doctors and hospitals as against what it would have been. And this comes from the chief actuary's office. And here's what private insurance is paying, here's what Medicaid pays. And the way the Affordable Care Act is written, if we implement it as written, then before this decade is out, in just 9 years, Medicare will be spending less for seniors, for doctors and hospitals, than Medicaid. Now, a lot of you probably know that people on Medicaid have trouble getting access to care. In a lot of cities around the country, they can't find private doctors who will see them, so they end up going to community health centers or they go to safety net hospitals. So it's not great for access to care. If we really did this, though, then seniors would be less preferred from the doctor's point of view than the welfare mother. Seniors would have even less access than Medicaid enrollees, and it would just keep getting worse and worse through time. Now, the chief actuary also said he doesn't believe we'll ever do this. That long before we get out 9 years from now, everybody in Congress will be hearing from elderly voters that say we can't find a doctor who will see us, and there will be such enormous pressure that they will undo all this. And that's what the chief actuary is predicting. That's what I gather people in the Congressional Budget Office also believe. Most people who've looked at this think this is never going to happen. If it did happen, however, this is looking out through time and shows you where the cuts are occurring. The blue bars are the hospitals, and these percentages are percent of what it was before the law passed. And what this chart says is that in 10 years, the hospitals will be getting only 80% of what they would have gotten under the old law. That's a 20% cut. Then it just keeps getting worse and worse through time. By the time we get out to 2080, well, by the time we get out to 2065, it's half of what they were going to get. This kind of sickly looking yellow color, that's the doctors. Within just 10 years, I'll be getting 90% of what they were going to get, and then it just keeps getting worse through time. The green line is the pharmaceutical, and it looks like the spending never changes. I was visiting with one of the pharmaceutical companies yesterday, and I said, "You guys made out like bandits." And they said, "Oh, no, we didn't. You know, that may be the spending, but they're going to make us give it back with all kinds of rebates and things." So, so if there's somebody here from the pharmaceutical industry, maybe you can tell us how well you made out. In terms of reduced spending on each senior in the different years, you can see that it keeps going down, down, down versus what it otherwise would have been. In terms of the whole package, you know, the present value today of what seniors lost, if you're turning 65 this year, the day that Barack Obama signed the Affordable Care Act, your Medicare benefits went down $36,000. Okay, that's the present value. That's in today's dollars what you lost as a result of that act. How did you lose it? Well, you lost it in terms of reduced spending on doctors and hospitals. The question is, and the really unknowable answer to the question is, well, what does this mean for the senior? If Medicare is spending that much less on him, does he have to make it up out of his own pocket? Is he going to have to top it up? Is he going to have to go to a concierge doctor? And we don't know the answer to that question. What is $36,000? That's equivalent of 3 years of benefits. If you are 55, you lost over $60,000. That's equivalent of about 6 years of benefits. And for the 45-year-old, he lost about 9 years of benefits, just in terms of raw spending. Been a lot of discussion about how good a deal do seniors get, and a lot of the numbers that are tossed around are really based on the old law. Now with the new law, it doesn't look quite so good. If you're 85, you're still doing fine. For every dollar you paid into the system in payroll taxes and income taxes and premiums, you're going to get $2.69 back in benefits. If you're turning 65 today, it's not nearly as good. For each dollar you pay in, you get $1.26 back. Everybody under the age of 50 is now going to get less from the system than they pay in. If you're only 25, for every dollar you pay in, you can expect to get back 75 cents in benefits. So back to the chart that we started on, if we could stay on that blue line, whether it's the Obama approach or the Ryan approach, that would be good for the finances of the federal government. But to do that, we've got to take a lot of money away from seniors. I'm going to turn it over to Tom in just a moment. Do you have anybody have a quick question before I do this? Yes, sir.
You showed the chart where the doctors and hospitals are getting paid less. More doctors are moving into hospitals. Does that make the doctors drop faster? And at what point do doctors just throw up their hands and walk away?
The chart I showed you from the actuary's office sort of combined them. But doctors working for hospitals still, the hospital still, I think, Tom, you can correct me if I'm wrong, gets compensated with the Part B levels of compensation, and if it's a hospital type service, it's Part A Medicare, regardless of who's working for whom. Eventually, people will walk away. And they're already walking away from Medicaid, and in some places they're walking away from Medicare. And my prediction is we're going to see a huge increase in concierge medicine. And I find that wherever I am in the United States today, if I'm a crowd of 20 people or so, there are always 2 or 3 hands that go up saying that they already have a concierge doctor. All right? Concierge means that doctor has left the system. And he may take some Medicare dollars, he may take some Blue Cross dollars, but the patient has to pay on top of that. And the average around the country is about $1,500 per person per year. What do you get for your $1,500? The doctor talks to you on the telephone. He emails you. You get same day or next day service. He helps you get your MRI scan. He's your agent in the system. What if you don't have a concierge doctor? Then the wait to get to see any doctor gets longer and longer and longer, as it is in Massachusetts right now. Concierge doctors are going to be created because people aren't going to want to wait, and those who have the money will want to pay more to get outside the system. Doesn't mean they'll leave Medicare entirely, but it means they'll be paying extra out of pocket in order to get the kind of prompt service that they have been expecting in the past. I'm going to turn it over to Tom.
Medicare reform, and John alluded to this, is really about who pays. These are some fundamental facts. So we've got to bear this in mind all the time. One, seniors are going to continue to consume health care. There's no doubt about that. Now there are a bunch of issues. A lot of research has been done that indicates that the way the technology has moved has a lot to do with the way Medicare operates. When Medicare came into being, the hospital beds mushroomed because suddenly seniors had money. There's a lot of good research on this, but that's not what I'm talking about here. But seniors are going to see. The second thing is, we're going to have to pay healthcare providers. I mean, we can pretend we're not going to have to. We tried to do that with sustainable growth. You guys, as those of you who know anything about this, done SGR, we know that that lasted about 7 years, and every year since then, for 8, now 9 or 10 years in a row, Congress has rescinded the changes in physician reimbursements that went with SGR because they're unsustainable. That's impossible. The third thing that's true is, unless you get some divine intervention, mandated miracles are not going to solve a problem. And I really mean by that, the interpretation of the Affordable Care Act by the trustees mandates a miracle. And the miracle is that suddenly something that's never happened in the past, because medical care is a labor-intensive industry, that suddenly its productivity is going to rise at the rate of the non-healthcare industries. Never happened in the past, but the bill says it's going to start happening tomorrow. Tomorrow it's going to start happening. And that's what everything that's in the bill is really, the Medicare stuff in the bill is based on that. And if that were to really happen, as I've said before, we can build a lot more highways if we mandated having the force of gravity. Because we would only need half as much steel and half as much cement. We could build twice as many highways. But that can't work, and this can't work. We can't look for a miracle. We've got to somehow find how we're going to distribute who pays, because seniors are going to consume health care, and you wouldn't want them. You certainly wouldn't want me not to have health care, and I know you wouldn't want your parents or grandparents. But I want to look at what are we talking about, and I'm going to do that somewhat as to what's happening. And these are projections really by Congressional Budget Office that don't pretend that we're going to consume healthcare forever. Of course, one reason we might think about why do we care about how much health? Because nobody seems to care about how much we're spending on the computer industry. And we've got to be very careful about looking at these numbers, because these are not about prices. And there's a lot of confusion when we look at charts. And it's nice that you have a bunch of young people, because at least you're used to looking at charts. But when we talk about healthcare, we're not talking about prices. We're talking about price times quantity. We're talking about total output. So it's when we see it going up, it doesn't mean prices that healthcare is costing more. It means we're buying more of it. It may be costing less, And we might, those of you who know some economics, you know about elasticity of demand. Demand's elastic. And my argument is that healthcare is a superior good. Wealthier nations and wealthier people are going to spend a greater share of their budget on healthcare because having quality life years is valuable. And we have an awful lot of research in how we value those. But in any case, the end of this, the top of this chart, these are percentages of gross domestic product. We talk about what the Congressional Budget Office was forecasting before the Affordable Care Act. And we could argue that this is the amount of health care that seniors want to consume. But this isn't all of their health care, of course. What this is really that part of it that's Medicare. Remember, seniors also pay, we have premiums, they pay premiums. Until the Medicare Modernization Act was passed, we never had a good handle on how much of these premiums were actually not paid by Medicare people, but were paid by the federal government. And now with Part D, suddenly that became apparent to everybody because there was something called dual eligibles, and the states had to reimburse federal government back for something. And that's when it became more apparent that there are a lot of people on Medicare who are also on Medicaid, and Medicaid was paying their premiums. So these premiums, while they're net revenue to CMS, are not actually all net revenue to the government. But forget that, that's a small, maybe 10% of the premiums. It doesn't matter. Here it is to give you an idea of what with the Affordable Care Act does. If we're going to consume the same amount of health care, and we're actually going to have, what it says is that the providers are going to pay. Now, they can pay in two ways. They can pay by suddenly becoming more efficient. Everything just goes faster. Instead of your doctor able to see you for 30 minutes, they see you for 5 minutes. Because that's what would be happening out here at the end. Because they can accomplish in 5 minutes what they used to do in 30 minutes. It's like you're going to the hairdresser, and the hairdresser takes 30 minutes to do your hair, but in 25 years, they're going to be able to do it in a minute. Of course, that hasn't happened over even the lifetime of anyone in here that's happened. That suddenly this new technology has made you spending a lot less time at the hairdresser or at the barbershop. And it's something that's very important. It also applies to education. Is that if you look at technology in the barbering industry hasn't changed in 100 years, but barbers are paid a lot more than they used to be. Why? Because everyone else has become more efficient. So in order for them to stay in barbering, you've got to pay them as much as they can get their alternative. That's also going to be true in medicine. We're going to have to pay doctors. We're going to have to pay hospitals. Or we're going to do what the chief actuary in CMS says, 40% of the hospitals are going to shut down because they can't make money in hospital. There are no nonprofit hospitals. There are only tax-exempt hospitals and taxable hospitals for profit. But no hospital stays in business if it doesn't make a profit. Here's the future of total health care, because we got to remember what we've talked about, all these graphs we've been drawing really are about Medicare only, not about how much seniors actually pay. And seniors pay a significant out of pocket. If you take a look at this sort of chart, something that's kind of interesting is these bottom two lines are always just about 25% of everything, okay? About 25% of all health care has actually been paid by seniors, both in terms of their premiums and their out-of-pocket expenditures. And we'd say, well, why is that a problem as long as that stayed constant? Well, as you can see, it's a pretty big problem because this difference up here grows from something like 1% of gross domestic product to 14% of gross domestic product. And 14% of gross domestic product is 140% of federal income tax revenues. So it says that if we're going to pay, if this general revenues are going to be like 140% of federal income tax revenues by the time we get out 70 years, and that can't happen, or that government's going to have to shut down. So let's get on with a few other things. Then there are a couple of ways to deal with this, because as I said, it's all about who pays. How are we going to equitably distribute the fact that seniors are going to pay for health care? They feel there is an entitlement to it because they have been paying these HI taxes since 1965. They've been paying into the system. They deserve it. Now, we don't call those contributions, by the way we call FICA. Remember, the Social Security stuff is called contributions, like you really don't have to pay it. It's not a tax. In this case, this is a tax, so you feel like, hey, they owe me. Here's the federal income tax increase required to fund entitlements and maintain the rest of government. Because if we'd like to say government's not going to go away, so we're going to maintain it, we're going to say in a decade we're going to have to increase federal income taxes by 12%, almost, over 42% in 20 years. And remember, the reason these first 2 times are important is that that's where the baby boomers are going into Medicare. That's what we're going to have to pay for. So if we're going to maintain the rest of government, we're going to, in 30 years, 65% increase in federal income taxes in order to fund these programs. That's not going to happen. That is, taxpayers aren't going to let it happen. The second thing we know for sure is, and I know Kaiser did this thing and they discovered, to their surprise, seniors didn't want to change Medicare. So, you're on the dole. They got an allowance. No, when you went to, if you guys have little kids, you're going to lower their allowance. They're not going to like it. Hey, I don't. If you're going to change Medicare, how should you change it? What we did with MMA and we had the drug effect. Were the seniors happy with having a drug benefit? No, it wasn't big enough. I testified 3 times before the Clinton Bipartisan Commission. Everybody else except me thought the way to solve Medicare's problems were to give their group more benefits. That's how you solve the solution problem. Give us more. Let the elderly pay. Here's the next thing. This is the share of projected median earner Social Security benefits that would be paid with premiums. So we let the elderly pay up. And as you can see, it would be 20%, but it would be, in 30 years, it would be 3/4. And in 40 years, 100% of their Social Security benefit would go to pay their premiums. And then beyond that, of course, they'd be getting a bill from the government instead of a Social Security check to pay their premiums in Medicare. That can't work. And so, as I like to say, it's all about who pays. You can means test. Let's just take away the benefits from the top people. Warren Buffett doesn't, Bill Gates don't need Medicare anyway. Forget it. And how many would we have to die? By 10 years, we'd have to take 20% of the people off the Medicare rolls. In 20 years, 43%. In 30 years, 55%. The real important thing is, what's the income cutoff? It would start in a decade at 60,000, but it'd be almost 30,000 in 20 years. That's a pretty small number to live on. And we would cut it. If you had more than that, you get 0 Medicare. That's a draconian solution. I've got just a couple of things here I want to do. Here's the effect of the proposed reforms. Just give you an idea of the percent of federal income taxes for the unfunded liability. John talked about it a little bit. This is the original CBO estimates of what happens to the unfunded liabilities, a percent of federal income taxes. It would have been 25%. And these 2 things, GDP indexing and CPI indexing, are the ways you would treat premium support, the Ryan plan. And you can see that it has a significant effect. Note that they're still all bigger except for consumer price indexing, which is an idea that we tried in Social Security. The seniors just go absolutely ballistic about it, and it's a bad. And what it does is make them pay the whole cost. As you can see, what happens with CPI indexing, it makes seniors pay everything. That's not going to work. You're going to have to somehow find an equitable way to share these deficits with taxpayers and seniors. You can't make taxpayers pay it all. You can't make seniors pay it all. We've got to how are we going to do it, and who's going to pay? But the providers have to be paid. If we can imagine we don't have to pay the people who provide, then we're going to depend on everyone to be Mother Teresa, and that is not going to work, and it cannot work. Let me see, we're down to the end here, and I'm going to just this is the last thing, required payroll tax to pay after Medicare reform. This is what the payroll tax would have had to have been to pay for Medicare. If you did the premium support stuff with gross domestic product index, you can see what it payroll. Still a lot more than now. Why is it bigger? It's bigger because the aging of the population. First, you've got the baby boomers. You've got this big bulge, and that's the fast rise up here. That's just the baby boomers retiring. But longevity is longer. As long as you're going to keep the eligible age for Medicare the same, you're going to have an aging population throughout your lifetime. And that means you're going to have to pay more in the end. Except if you consumer price index, which cannot happen because that makes seniors pay everything. So it won't work. Now these are the issues. We're going to have, the bottom line is, we're going to have to consume health care. We're going to have to provide it. And we can't legislate a miracle. We're going to have to find a hard thing. And this is really hard politically. You've got seniors who don't want to take any less. They vote and they give money to politicians. That's what I tell my students, 20 years old, I say, seniors do 2 things you don't do. They vote and they give money to politicians. Kids in class, 20 years old, they don't vote and they don't give money to politicians. Who do you think is going to get screwed? You guys are. and this is what your taxes are going to be. And that's what's going to happen to you, because seniors are going to hate all you people when you try to say, we got to change this. And that's the bottom line. If you have any questions, I'll be glad to take them.
Anybody have a quick question while we're... Yes.
How much of the change in healthcare spending is driven by demographics, and how much of it is the actual inefficiency in the system? I mean, I guess the thrust of my question is that just like Social Security, you would have this rising healthcare spending just with demographics. I mean, if we had a baby boom again, the per capita spending on tricycles would go up, just the way healthcare goes up because you have more seniors.
Well, there's no doubt we can separate out the demographic effects people have. I mean, CBA, you can easily do that. I mean, the latter part of your statement just pretends that that waste, fraud, and abuse is an easy thing to do. Everybody has waste, fraud, and abuse. You know, Walmart has waste, fraud, and abuse. And who pays for waste, fraud, and abuse at Walmart? Customers. We all pay. We all pay for waste, fraud, and abuse. Why don't they get rid of it? You know, it's easy to say, hey, let's get rid of waste, fraud, and abuse. And if Walmart knew how to do that, they do it at the margin. And when in 2000, this is a little story about, I was a trustee, and the Department of Justice, we decided to go after doctors who were upcoding. And upcoding means you go in for a flu shot, they charge you for a pneumonia shot, and since nobody's paying, they don't even care what the doctor checks off. What do you care? You're paying $25 for an office visit. You don't care if he's charging Medicare $1,000 or $10. You don't care what he charges them. So we did this, and our estimates for what was going to happen to Part B, which would have been physician reimbursements, were overstated the next year. Now, I don't know how much, it's not clear. This was never done again. Probably it cost us a huge amount more money in the Justice Department to do it than we saved. But I used to tell my fellow trustees, why don't we have federal agents at the grocery store when people are checking out to make sure that the clerk is not upcoding you? And I said, the reason we don't is that every person is the federal agent. They're watching the person. The reason that we have these problems with Medicare is that nobody pays. And if nobody cares what it costs, the suppliers also aren't going to care what it costs. But I think that to imagine that waste, fraud, and abuse is going to solve our problem, it's rounding error to this problem.
But to the first part of his question, is it correct to say that the rise in health care spending is overwhelming the change in demographics, that the first problem is much bigger than the second? Is that right?
I would say over this next decade, probably not. But in the long run, I think healthcare all over the world, I mean, healthcare is a superior good. There's no doubt about it. Quality life years are valuable, and people are going to pay for them. And as we get richer, we're going to buy them. But that's okay. And remember, it's not about price again, it's about quantity. And that's where all this confusion comes from, because a lot of people want to assert that it's because it's because we're consuming more. When people say, hey, the insurance companies are charging more, well, almost all the health insurance in the U.S. is really self-insurance by the big firms. And when those premiums go up, what does that mean? It means they spent more last year. So it's really about the amount we're spending. We can blame it on the insurance companies, and in campaigns, that's what the campaigners always want to do. But the real thing is, it's pointing it at the people the way in the Carter administration, they pointed at us when there was inflation. And remember Fred Kahn, who's an old friend of mine, Fred got up and said, it's your fault. And he meant all you people out there, you're spending too much. The government's printing money like crazy, but they're blaming us for spending too much. And that's what Fred actually did that. He's the guy who's responsible for airline deregulation. Fred was a great economist. He got into Washington, and the line was that it couldn't be their fault. So it had to be our, and he actually got on television to tell us all we were spending too much. We've got to get over that. We got to say we are going to consume health care. It's going to be good for us, but it's not about price, it's about quantity, and we've got to make sure we understand that instead of trying to pretend that people are overcharging us when it's really about how much we want to consume and how do we control that.
Thank you, sir. Now, I put a bunch of plans up on the graph a little earlier, the Affordable Care Act, what some of you may call Obamacare, and then you had the Ryan plan, and then you had the Debt Commission plan, and then Ryan Rivlin and Rivlin Domenici. Well, in addition to all of those, the Peterson Foundation paid some think tanks here in Washington to come up with their own plans. And there was a Heritage Foundation plan, American Enterprise Institute, and I think there were 6 in all. And I wrote a review of it, and basically my review of all the think tank plans was similar to my review of the plans that you have seen, that basically they were just lines on a graph. I mean, they all said, well, we're not going to let Medicare grow any faster than the price index, or it's not going to grow any faster than the gross domestic product. And but in doing this, of course, what they're all doing is shifting costs to somebody else, to a taxpayer, to a senior citizen, without giving that senior citizen any new tools to deal with the problem that's getting shifted to him, without giving patients or doctors any new tools to comply with the lower level of spending, or without giving young people any new tools to allow them to better pay for the care that is not going to be provided by the federal government. So what we did at the NCPA, working with Professor Savings and his colleagues, was ask, well, what would a real reform look like? What if we wanted people your age to be able to reach the retirement age and get similar health care to what people are getting today, and get similar Social Security benefits that people are getting today? What would we have to do in order to do all of that? And for Medicare, we came up with 4 things that we had to do. Why is this not moving? Thank you. And the first thing that we said we have to do is we have to convert Medicare. We have to at least give seniors the opportunity to have the same kind of insurance everybody else has. And what seniors have today is a very lousy health insurance plan. Medicare has all kinds of holes in it. It exposes seniors to all kinds of catastrophic costs. So they go buy Medigap insurance. But even after they buy that, they don't have decent drug coverage. So then they go back to Part D insurance. So now the typical senior is paying 3 premiums to 3 plans, right? And even with that, they're still exposed to tens of thousands of dollars of cost if they stay in the hospital too long, or if they need a cancer drug. And so they don't have the kind of insurance that all of you have. So what we proposed, first of all, was let's let them have the kind of insurance everybody else has. One comprehensive plan that pays all the catastrophic costs, but lets them pay a lot of the small dollar stuff that almost everybody can afford. And then to help them
Turn it around.
do that.
Turn it the other way.
Oh, okay. Thank you, sir. Going backwards. To help them pay for that, we create a Roth Health Savings Account. So money they are now giving to the Medigap insurer, money they are now paying out of pocket, they would be able to put into this account and pay their share of medical bills. Number 3, on the doctor side, doctors have to be free to repackage and reprice their services. We can't continue with a system where every time a doctor does something that makes the system more efficient, he gets less money. It's got to be the other way around. If guys at your hospital in Pennsylvania says, okay, we want to get really efficient, we're going to have a warranty on our heart surgery. If we screw up and the patient has to be readmitted, you don't pay twice. What I told the Bush people when they were in power is you ought to get on the telephone and tell Geisinger, we love that. Warranties are worth something. You're saving the federal government money. We want to pay you something for that. We'll pay you 50 cents on the dollar or 25 cents on the dollar for what you're saving us. And then after you've done that, you tell every other hospital in the country, we're open for business. We'll pay you a different way. If you save us money, you raise quality. Well, the Bush people thought that was the most radical thing they ever heard of. Little did they know what the Obama health reform was going to look like. But the Obama health reform is no better than the Bush people on this score. I mean, they don't open their doors to the provider community and say, tell us how you can save us money, improve quality, we'll pay you a different way. Instead, their whole philosophy is, we'll start in Washington, we'll tell you how to practice medicine. Do it our way, and we'll pay you more, and do it some other way, and we'll pay you less. We need to free the doctors. The top part frees the patients. And then the last element is for everybody who's not yet in the Medicare system. If the government's going to spend less on you, there has to be a way that you and your employer can start putting money aside today in order to make up that difference. And we calculated that we need about 4%. If you want to think of this like a payroll tax, 2% from the employer or 2% from the employee. That's what needs to go into the account. And if you do that, then Professor Saving and his colleague have calculated, here is with the $2,500 deductible, here's what the current system looks like in terms of percent of gross domestic product, and here's what could happen with money being contributed to the accounts. What this means is we would get out to mid-century and we'd have a payroll tax about the size of what it is today. Here's the same graph with a higher deductible, which it really probably should be a higher deductible, but again the same result. We get out to mid-century with a payroll tax no higher than it is today. So there is a way to reform the system, creating modest good incentives for patients, modest good incentives for doctors, allowing young people to save, and eventually get out to the point where people your age can get the health care that they are expecting without a huge burden for taxpayers. But I don't want you to think that the whole thing is going to be easy, because here I have just thrown together the Social Security part, the Medicare part, and the Medicaid part, and all this is sort of back of the envelope. If we want to have your generation make it through without the entitlements programs creating huge new burdens for taxpayers, you need to start today put aside 4% for your Social Security, 4% for Medicare, 2% for the elderly parts of Medicaid. That's 10% of your income. That's not small. But that gives you some idea of the dimensions of saving that we need to be doing right now in order to avoid the calamity. So that's a big hit. It's not small, but it's doable. Okay, that's all I want to wrap up, and we'll just open it for any question you have for either one of us on any of these topics. Yes, back there in the back.
Is that 10% into a personal account, or is that into a government account?
That's 10%, that's yours, but you're in an insurance relationship with other people, and you can't just immediately have it. Yes.
So, question about why you're calling the Ryan plan cost shifting. It seems like it is changing the incentives involved in Medicare by giving seniors, premium support where they're going to go and pick an insurance plan with that fixed amount of money, so that there's at least some cost consciousness being introduced in Medicare. So it's not just a cost shifting; it has a potential to realign incentives to put downward pressure on future spending.
Well, I like the structure of the Ryan plan. And by the way, so did Alice Rivlin, who's a liberal Democrat. And the way I think of it is just an extension of the Medicare Advantage program. And 1/4 of all the seniors are already in a Medicare Advantage program, and they really like it. And they do get to choose, and there is competition. The question is, how much is the federal government going to contribute to these plans? And the criticism right now of the plans is the government's contributing too much. And that may be correct. But what happens with the Ryan approach is it's going to spend even less on these plans than the Obama administration is going to spend. But both of them together are going to spend too little. So there are two questions. One is the cost shifting part, and the other is how do you get your health care? Yes, it's much better if you have a private insurer combining all the parts of Medicare, one premium to one plan, let it be comprehensive coverage. Yes, that's ideal. But now, how much do you pay and how much does the government pay? That's the issue here.
What's the idea? Because these reforms are occurring off in the future, right. So seniors are going to have, people are going to have the opportunity to save and accumulate funds, so that they'll be able to top up whatever their government contribution is.
Well, that's right. But, you can ask, why do we have Medicare in the first place? I mean, couldn't everybody have saved when you're young so you can pay for health care when you're old? I mean, couldn't we all do that? And the answer is yes. I mean, you can say the same thing about Social Security. Why do we need it? Can't we save when we're young for our retirement income when we're old? Yes. So if you're comfortable with that, then fine. But the standard argument is that too many people won't save, and they'll reach the age of 65, and they'll have nothing to live on. They'll have nothing to pay for their medical care, and so everybody else is going to have to pay for it. So that's kind of the reason why we adopted these coercive programs. Now, if you buy that argument, then you have to say of Paul Ryan, well, okay, yes, young people could save knowing that the government's going to spend less. You're making them pay their Medicare taxes. Why are you letting them have an option about the amount they're saved? If you really want to make sure that people reach the age of 65 and they're able to afford the health care that you want them to have, it seems to me that we ought to be coercive on both parts. That A, you have to pay taxes, but B, you have to save. You may not agree with that.
Yeah, right. Well, I think part of the response to the question is the argument is that somehow we have to try to see if we can make markets mean something. I mean, and you people are all too young to get in hospital bills, but every price on a hospital bill is fiction. There's not a single price in it that has any real meaning. You go off to we're in Guatemala City. You go into one of these hospitals that does tourist medicine. They've got a list of you go to a desk. You can pick up little price lists. That's what it's going to cost. They had time of day pricing for the MRI, time of day pricing for sonograms. Everyone knows what the price is, and they're actually going to pay it. One thing that premium support is supposed to do, or vouchers as I like to call it, but they get all upset when I say the V word, because in Washington the V word is not a good word. But anyway, the premium support is that the difference is going to be paid by a senior, and that means that the providers are going to have to bid for that senior. And that's the difference between Medicare Advantage now is, of course, a capitation payment is decided by CMS. And the only way that HMOs can bid for that is to maybe give you something extra. But here they're going to bid on price. And it's that bidding on price that can matter. And that's that bidding on, and the issue is we don't really know how big that effect is. We could imagine that our overestimates of what was going to happen with Part D, because when I was trustee when Part D came in, and we way overestimated what was going to happen the cost of Part D, because Part D, what we did was assume the pharmaceuticals would continue to rise at their historic last 5-year level. Of course, the competition to get these seniors in Part D reduced the cost of pharmaceuticals significantly. So we way over it, and the next year we overestimated again what Part D was going to cost, underestimating the impact of competition. And I think competition can be big, and I don't know. The problem is none of the experiments that we've tried to do, the old RAND experiment, the new thing that RAND that's recently been published, I've forgotten the journal it's in, a very interesting piece that talks about how much less people spend when it's their money. But that's how much less they spend. Those experiments are too small to find out to make providers compete. And it's what providers competing to do the things John's talking about, to make their product better and cheaper. Because as we already know, cosmetic surgery and LASIK surgery have become better and cheaper for the last 20 years, continually. And everything else becomes maybe better, but certainly more expensive. And the question is why? What's the evidence? We need a big experiment. And I think somehow we have to decide who's going to pay. And Ryan's approach, that is premium support, which was also, remember, the Clintons' bipartisan commission's approach. Really all they've done is to pick up what the bipartisan commission, the Clinton commission, recommended, and that is premium support. And allowing people to go out and make the providers compete for their money. And then they'll watch what they spend. It'll matter. They'll be like you at the grocery store, making sure that you don't get upcharged, but also more quality, because quality is going to pay. The hospitals will have to say, well, here's our quality. The only time that's not true is when you're in trauma cases, and that's what everyone likes to talk about. But that's a small part of what we're talking about in terms of Medicare. Most Medicare expenditures are not trauma. So all the other things are choice. And I think it's important for us to be able to do that.
Who else has a question? Anybody? Charlie, you have another question?
I was just thinking more about doctors and the concierge care. There's a doctor in Oklahoma, Dr. Keith Smith. He opted out of the system, and he just had a patient that went and got a $20,000 quote from a hospital, and he did the surgery, double knee surgery, for $5,600, and that's care here, cash, and he's fully opted out of the system by not taking insurance. And I think you touched on concierge care, where they're kind of taking insurance, but do you see a full opt-out maybe happening more? And if you see a full opt-out, does that change this plan at all?
Here's what I think is going to happen. I think that private insurers are going to go to something called value-based purchasing. And what that means is if you need heart surgery, they're going to say, you go over here to our hospital and we'll cover the whole thing. But if you want to go to some other hospital, we'll put up the money we would have spent on you over here, and you can take the money with you, and you can add your own money, and you can get your care anywhere. Now, what that does is that makes the concierge movement really easy, because it means that doctors can then step out of the insurance system, take whatever the insured Blue Cross pays, you add to it, and I think that's the way it will go. So we'll never leave the insurance money on the table, at least most doctors won't. And Medicare, I think, will work much the same way. They'll figure out a way to get the Medicare money. They'll claim that everything else they're doing for you are services Medicare doesn't cover, so it's totally legal. But they'll game the system. And the problem with the whole concierge idea, by the way, is think of primary care. A doctor with 2,500 patients leaves the system, takes 500 patients with him, leaves 2,000 behind. What are they going to do? The 500 he takes with him, they can talk to him on the phone, email, all this great service. The 2,000 left behind have one fewer doctor to see. And I think we're going to go very quickly toward a two-tier system.
John, that would be true, of course, especially if Medicare did what the Canadian system did, which meant, or like the British system. If you opted out of the British system, you didn't get anything. So you went to the private sector, it's like the public-private school issue. And so this becomes exactly that same kind of an issue. You want to send your child to private school, you still have to pay all the public school taxes, and the question is that the way Medicare would work? Nobody really knows with the Affordable Care Act how, in fact, these reimbursements would work, and whether they would allow people to step out the system and still get their reimbursements for whatever was performed, and the doctor would charge a lot more, and nobody knows how that would work. That at this point, we don't know what's going to happen. But those would be things that you would certainly want to allow, but they still make Medicare cost more than it would otherwise. And it's this whole issue about who pays and how much we're going to make the seniors pay, how we're going to deal with the people that are chronically ill. Of course, the Ryan system was going to do that by using the same kind of criterion that Medicare Advantage used in the capitation payments. They were going to make the premium support reflect whether you're chronically ill or not. So the amount of money you were going to get was going to reflect that. So that's easy to do in a sense. But because remember, risk in healthcare is not about risk in any other part of the industry. In finance, risk means uncertainty. In healthcare, risk means higher expected costs, not the variance. Risk is variance in everywhere else, but in healthcare, risk is the mean that we're worried about, and that's what Medicare Advantage tries to do. And you could do that, and that's what the premium support was designed to do, and that's what the Clinton's premium support would have done too. It was to be designed the same way.
Yes.
The line which defines Obamacare plus, same thing as Ryan plan, is that somewhat misleading because it's not describing the total amount of, it doesn't describe the total cost of healthcare for people 65 and older. It just defines what the government contributes to the care of those people that are 65 and older. So it doesn't reflect the fact that people 65 and older under the Ryan plan would actually have to pay a considerable amount, perhaps 50% or more of the total cost of their care out of pocket, whereas the Obama Medicare Trustees Report, is saying that the government is negotiating rates to keep the cost of care for those 65 and older population at that line.
Let me do this again. And I don't think a lot of Republicans understand this. For the next 10 years, they're the same, right?
But that's not what the issue is about after.
Well, let me just finish. For the next 10 years, it follows exactly the same thing. Then, Only people who are 55 and younger, then they start going to Medicare, they get a different deal. They get everybody over 55 is still under the same system as current law. So for everybody over 55, it's as though they never left what you're calling Obamacare.
Right.
Yeah, but the question was about what is
My question is
that? What is the care?
Well, my concern is that someone could take your graph and say that Obamacare and the Ryan plan both cut the same from Medicare.
They cost the same for the government. That's right. That line, that's junk.
For the next 10 years.
Well, in a sense, though, this says that they're going to cost the same for the government. Because this has to do with the government share. Your question has to do with if my graph is talking about this is how much health care we're going to consume. We are going to have to pay the people who provide. We can pretend like the trustees did, and the way CMS did the trustees report. Remember, now that is not necessarily in the bill. If you read that part of the bill, if you can figure out what the world says, I mean, that's not easy. I've read the part of the bill. It's very complicated. What does it mean? But the interpretation that the chief actuary gave it was that what it means is we're going to apply this rate of growth and productivity outside healthcare to our reimbursements. Now that doesn't mean that healthcare providers will show up to work at those reimbursements. And the question is, if we're going to have to pay them, who's going to pay the difference? Or if we're going to say you'll have to wait in line, that's all. And if you step outside, you have to pay yourself. None of that's there, and that's really what your question is about. The question is about both of these things mean that seniors have to pay more. That's what I was talking about. We have to share the cost. We are going to have to pay providers. We're going to have to share the cost between taxpayers and the elderly, no doubt about that. And that's going to be true. It's true in the Affordable Care Act. We're going to have to share. And the Ryan thing, we're going to have to share, because the Ryan makes it more explicit, because it's saying that seniors are going to get this premium support, and they're going to have to pay the difference. And the question is, what's the difference going to be? That we know what the premium support would be. It would be along that line. For example,
I guess when you start with the GDP plus 2, you're saying this is the rate at which healthcare is growing.
And it has been growing.
Right.
Now,
and so what I'm saying is, whereas Obamacare tries to negotiate rates down and make cuts on the provider.
Without negotiating, they're going to set the rates.
Well, yeah. So they're bending the cost curve. It's a miracle. They're trying to bend it, but they're bending it because they're cutting.
Yeah.
Let me do it this way.
Whereas Ryan is going to.
We're saying
bend.
Yeah, exactly. The question is, can you go outside the system without an affordable care?
Let me do it this way. We've shown both on this same blue line here.
Right.
How do they get there? For Obama, it's we're going to squeeze the provider.
Right.
For Ryan, we're going to give you less for your insurance, but we're going to leave the provider community free to do what it wants. So yes, there are two fundamentally different approaches.
Yeah,
but SGR, we already know, hasn't worked.
Right.
Yeah, and none of the trustees. So really, I want to be more generous to the Affordable Care Act and say that what would happen is that it would be a way to set reimbursements. And the difference would then have to be paid, because as soon as all the seniors come in and say, no doctor will see me, Congress isn't going to let that happen. So and that's what even the administration trustees say that on page 3 of the trustees report. This probably can't happen. And that's unique. There's no trust. The 2010 and 2011 trustees reports are unique in that sense, that every trustee. And I was in both Democratic and in Republican administration trustees. That is the administration people, Secretary of Treasury. They all did not want politics. Neither the ones under the Clinton administration nor the ones under the Bush administration wanted politics to enter the trustees report. And in effect, it didn't even in the 2010, 2011, because they all say that we don't think this can happen. And, the way the trustees wrote it, if I look at the Affordable Care Act, I can't see where it's going to require this productivity thing. I read it all, I can't understand what it's really telling me. So it really depends on what's really going to happen. But clearly, seniors are going to have to pay more. and they aren't going to like it. And taxpayers, and we have to find an equitable way to do that. I don't know exactly what equitable is going to mean, and whether equitable means you can get on this path or not, probably not. I'm suggesting probably not, because healthcare is a superior good. We're going to be a wealthier country. We're going to want to consume more. For it to rise faster than GDP would not be, faster than income would be what we would expect of something that people think is something really important to them. It doesn't have to rise faster, because as long as non-healthcare expenditures are still rising, there isn't anything wrong with healthcare expenditures rising faster than GDP, because non-healthcare are rising also, slower than GDP, but rising. So you don't get to the point where it crowds out everything, because we know that can't happen, and that's the reason why when we were trustees, we never would let GDP plus 2 go out to 75 years, because in 75 years you wouldn't have anything but healthcare, and we'd say, well, that can't happen. But I remember my first arguments with the actuaries was they said you can't have it growing faster than GDP, and I did a little math for them. They were mathematicians too, to show them that no, that's not, it's false. Certainly can always grow faster than GDP as long as non-healthcare expenditures are also growing. So it can go to infinity, and both of them are going to infinity, of course. But in the end, as we get out here 1,000 years, our income, it's going to be huge.
All right,
but
yeah.
That's the issue. But those are exactly the right points. And that's really the points I was trying to make. Who's going to pay? How do you distribute who pays? But we are going to have to pay. To imagine we don't have to pay the providers, that's a miracle.
All right, thank you all for coming. If you want to stay around and ask a few questions privately, you may do that. Thank you.